discussing diabetes, finding out exactly how preventive we can be about it, what we can do in the eventuality that we do have it or someone in our life has it. And of course, just learning. I think that's the name of the game, right? Just making sure that we leave this day a little bit better and a bit more informed than we came in. Of course, Dr. Rilwan is with us as well as Dr. Shilpa. And I wanted to just maybe get an idea. I know a lot of us understand diabetes and sugar. We're just like, okay, inaitwa usukari in Kiswahili or something of the sort. So just think diabetes, sugar. But could you explain to us, Dr. Rilwan, exactly what diabetes is and the types of it? Yes.
Okay. Thanks, Mariam. I think it's probably kisukari. I think
kisukari. Yes. Usukari. What is that?
Yeah. So diabetes, like you said, is just that high blood sugar in your blood. So if I could get as layman as possible, that's probably how I can describe it. And why do you have high blood sugar? It's because there's a hormone called insulin, which should ideally be removing sugar from your blood and taking it into your body cells. So when somebody has diabetes, they either lack this hormone insulin or they have the hormone insulin and it's not acting like it's supposed to. And then comes the type of diabetes. So when you have diabetes type 1 is when you do not have the hormone insulin. And hence people with type 1 diabetes require insulin, which is an injectable form of therapy, as their form of treatment. Previously, we used to call type 1 diabetes juvenile or childhood. We no longer use those terminologies because we now have adults who are getting type 1 diabetes and they completely lack insulin and they require insulin for therapy.
So you can have insulin in your childhood and not in your adulthood?
Yeah.
Okay.
So previously, when you don't have insulin completely and you have type 1, it used to be childhood. But now research has shown that it can also happen in adults. And so now comes the type 2 diabetes. Type 2 diabetes, essentially, initially these patients have insulin, but it's not acting well. And so these are the people who probably start on oral medications. They take their medications orally. But this is the thing, because we get a lot of times patients coming in because type 2 diabetes at a certain point may need insulin as well. So what happens to your body is when you have the insulin, but it's not acting well, what happens is the insulin in your body, the high sugar in your body, if you've had it for a long time, ends to your body completely depleting the insulin. Sort of the sense that the organ that's supposed to produce insulin is your pancreas. So when you overwork your pancreas by your sugar being high all the time, because the pancreas is stimulated to produce the insulin when your sugar is high. So when your sugar is consistently high, this pancreas is overworking to produce the insulin. So I always tell my patients, it reaches a point your pancreas gets tired and says, you've overworked me, I can't work anymore. And so it completely stops producing the insulin. And so these patients who were initially using oral drugs end up using
injectables.
Injectables.
Okay.
So type 2 also can use insulin. The other type of diabetes is gestational diabetes. This occurs during pregnancy. And it occurs during the second half of pregnancy, mainly after 24 weeks. And so these patients, after giving birth, usually the sugar goes away. But these patients are predisposed to having very high chances of having type 2 diabetes later on in life, especially if they're overweight and obese. And they have a family history, they tend to develop the type 2 diabetes later on in life. There are other types of diabetes which are genetics, which happen because of genetics, entirely a genetic issue, which we call MODY. And we have what we call latent autoimmune diabetes in the adults as well. This is a sort of a mixture. Initially starts as a type 2 and then ends up as a type 1. And then we have those that are predisposed secondary diabetes, which happens because of some drugs that we use for certain other conditions, like prolonged steroid use could initially end up getting type 2 diabetes. And we're having a lot of that lately, I think, because of
when you say steroid, do you mean like for athletes or
steroids? So not
or hormonal
Steroid is a drug which we use as an anti-inflammatory.
Okay.
There are some pro-inflammatory conditions, like when you have autoimmune conditions, we tend to use them. But lately in the society, we've been seeing a lot of skin lightening that has been going on, and patients developing, which are steroid-based.
Okay.
And they tend to develop diabetes secondary to that as well. Yeah.
Maybe Dr. Shilpa can tell us, some people get told you're pre-diabetic, you need to do X, Y, Z. What does that exactly mean? And then, of course, are some people more predisposed to diabetes than others? She's covered the types, but yeah, are there some things that predispose you to diabetes?
Yes, absolutely. So first and foremost, the history of diabetes in the family, in your first degree relative, your genetic makeup. A Caucasian has less...
Could come a bit closer to the mic, yes.
A little bit less propensity to develop diabetes in comparison to somebody of Asian descent or Latino descent. The other thing is obesity, lifestyle changes, and yes, obesity. Those are the predisposing factors. Everybody should be screened for diabetes from time to time. Those with the risk factors more often. Those with risk factors, which if we look into our past, all of us are going to be categorized into having risk factors. So at least once in a year, I do recommend, and it is recommended to do screening. When we say screening, there are two ways of doing it. We can do a random blood glucose, that is a finger prick, or something that we do in a laboratory, that's a random blood glucose. That can pick up diabetes or pre-diabetes. But I think to be more specific, a 3-month blood sugar average that is done gives us a lot more information if the other blood parameters are good. And we say that an HbA1c of 5.7 to 6.4 is pre-diabetes.
Okay. So if you're pre-diabetic, what next? Is it something that can be reversed so that you don't end up actually getting diabetes? Or is it more of like managing the situation?
So the terminology is, we call them persons living with diabetes or persons living with pre-diabetes, PWDs. A person living with pre-diabetes can, with the right lifestyle management, and occasionally we do need to add on some drugs to push them into what we call remission. There is no reversal or cure to diabetes as of today. It is remission. So we push them into normalcy with a normal HbA1c. They do require to be on regular follow-up. They are predisposed to the same complications as the persons living with diabetes, a little less so. So yes, they need follow-up. Occasionally they do need medications. Sometimes we can put in the lifestyle modifications and advise lifestyle modifications that can put them into remission and then stop the medication. But they do need to be on close follow-up because they can develop the same complications as persons.